Thanks so very much. I'm so very glad to be here with all of you. I am a real fan of the museum, so therefore a fan of everything that the museum does. It is my very great pleasure to introduce my friend and my colleague, Dr. Jim O'Connell, who is a pioneering leader in healthcare for individuals experiencing homelessness. Jim is the founding physician and president of the Boston Healthcare for the Homeless program. He has dedicated his career to providing compassionate, patient-centered care to some of the most vulnerable citizens of our community. For nearly 4 decades, Dr. O'Connell has worked on the front lines, treating patients in shelters, on the streets, and in medical respite services, helping them to redefine how we think about healthcare, housing, and dignity. Jim is the author of Stories from the Shadows, Reflections of a Street Doctor, which is a powerful collection of essays that illuminate the humanity and resilience of his patients. His work has not only transformed lives, but has also shaped national conversations on homelessness and health policy. And for our program this evening, of particular note is Jim is the subject and the main character of an incredibly wonderful and sensitive book by Tracy Kidder called Rough Sleepers. And so this evening, Jim and I are going to talk together. I always enjoy talking to my friend Jim, and we're going to talk for a little while, and then we're going to invite you also to join us, either by raising your hand so you can ask a question, or by putting something in the chat so that we can take a look at that. So first off, Jim, good evening to you. I'm glad to see you.
Oh, I'm honored to be here, and I'm kind of intimidated. I see an awful lot of old and very dear friends on this call, so hello to everybody.
Well, if you want to reach out and actually want to just speak someone individually, just go right ahead so that you can catch up with folks you haven't seen in a while. So Jim, let's jump in. You have been doing this work for a while, and I want to start from kind of beginning about where your work actually started. I'm wondering if you could talk some about what drew you to working with people who are homeless, and what made you stay beyond that first year.
Sure. I always, just to start out with, I always feel a little bit awkward because I did this not by any design. This just happened to be what I had to do when I was finishing residency, as many of you may know. And I didn't know anything about homelessness back when I started, other than what I had seen as a resident. I trained in medicine at Mass General Hospital. We had seen lots of homeless people in the emergency room, but I'd never been to Pine Street Inn, didn't know anything about the Boston thing. So I really, truly took this job under some duress because that's what my chief of medicine wanted to do. He was working with Mayor Flynn, and they were looking for a full-time doctor and couldn't find one. So I got conscripted. So most of what has attracted to me to this job happened after I took it, not why I took it. So I think I think I always have to be honest and say that I wish this was by design, but it was not. It was entirely, a wonderful accident of history and luck. So.
So
And
talk.
I loved it. Once I started doing it, I loved it.
So you got conscripted, and then you got in. So maybe the question is, what was the hook to actually what turned the switch for you? Because you ended up staying much longer than you had intended to stay.
Yeah, I don't know, Harold, until he died several years ago, my father asked me for all of these almost 40 years when I was going to get a job. So it was really, um, it was not exactly clear to him. Um, but you know what? I think what happened is even though I did get conscripted, I got thrown into a world I didn't know anything about, learned everything I learned from the nurses who were basically old BCH nurses down at Pine Street Inn doing a clinic. And then I had the chance to move. I went to Harvard Medical School and went to MGH, and I didn't know anything about the whole amazing world at Boston City Hospital, Boston Medical Center. And I think lots of things attracted me. When I got there, I was surrounded by these amazing people, many of whom are on the call right now, who were doing this just incredible work in these diverse kind of fields with different populations. And I felt instantly like this is where I belong. It was a wonderful large tent for people interested in finding how to care for people that were left out of others' care. And then I think the other thing that really caught me, not quite right. It was the very beginning of the AIDS epidemic as it hit the homeless population. We had seen it, when I was a resident, we had seen it from 82 to 85. But the first person that we knew of with AIDS who was living in the shelters was 1985. And within no time, it became an overwhelming thing. At the same time, as many of you know, we had an outbreak at Pine Street of multi-drug resistant tuberculosis. There were 60 people who had TB that was INH and strep resistant, requiring 4 medications every day for 18 months. And I got introduced to this amazing world of public health. I knew nothing about public health, but I knew a lot. I thought I knew a lot about TB and how you treat it, but I had no clue what to do when it's in a shelter going like wildfire. So working with the hospital pulmonologist, it was John Bernardo, Ed Nardell, lots of people you would know who were coming to the shelter. So I got to be part of a real expert endeavor, and I learned a ton. So I think it was those twin epidemics of AIDS and tuberculosis that just called out how we needed everybody on board to try to take care of this, or people were dying. And I was caught. Once you could be part of that, even if it's a small part, it just was addicting.
So you were right in the middle of two very important and complicated health issues. And one of the things that you often talk about of when you were getting grounded in this is your experience washing feet. Could you talk some more about that?
Yes. Um, I like the way you say it was my experience. I think it was more my when I've told this story, and if you've heard it, forgive me, but I got to Pine Street Inn, never having seen Pine Street before, not even realizing that there was a really fabulous nurses clinic there. But I figured the nurses would be thrilled to have me. My first job as a doctor, and they hadn't had one yet, and I thought they were going to be thrilled. And as all of us know from having my oldest sister is a nurse, so I should have known better. But they were really harsh on doctors and hospitals for not doing very much to help homeless people. And I was kind of the messenger that was slain more ways than I can imagine. Uh, but what they did is they just explained to me that we had been trained all wrong, that going fast and trying to see people on your own, not in a team setting, but on your own, go in, get somebody to tell you what's going on, examine them, make a diagnosis, treat, and move on. Never works with a homeless person because you've got to earn their trust, as the nurses showed me. And the way they told me I had to learn trust earning was to soak people's feet, which is what they did. It was this amazing. I was blown away when I saw it because I got into Pine Street's clinic. The the the, uh, the lobby was chaos. You had 800 people back then, 700 or 800 people, total chaos. You walk into the clinic, and it was almost like sacred space. And around the periphery of the waiting room, the nurses had set up these chairs where everybody was getting their feet soaked, and that was their offer to people to come in, sit down. They didn't do any pressure about, are you hearing voices? Do you have any chest pain? None of that. And they took away all my doctor stuff. I couldn't even use my stethoscope because they thought that was putting me in the personal space of people in a whatever the length of a stethoscope is too close to somebody's personal space when they don't know you or trust you. So I learned from Barbara McGinnis, who was the nurse who really taught me all of this, who actually was the state TB nurse assigned to Pine Street Inn. Uh, and that's what I did. I soaked feet, and it was, I resented it for about a week, and then came to cherish it for the next 2 months that I was doing. She called it my apprenticeship. That's what I had to do.
I was waiting for you to get to that place of the regret because I suspect that so you came in big time doctor, having gone to fancy school, worked in fancy hospital, and now you're being told by nurses that you're not all that. So you having to actually deal with this business. And I'm wondering if you can just talk a little bit more about so what that must have actually felt like to be actually be told, you, big time doc, being told by nurses. And I know that we've got nurses here in the house, so I'm this is homage to nurses. Please talk to us about what that was like for you, young whippersnapper, to actually be told, you're not all that.
Mm. it was even there's one, it was even one dimension worse than that, Harold, because remember, I didn't get to medical school till I was 30. So I'm 37 years old getting my first ever job. And I figure I'm way behind. I got to get there. I got to do it. And then running into this phalanx of nurses who said, nope, slow down, was initially, um, I guess frustrating is the way I would have put it, because I kept thinking I was going to do an oncology fellowship down at Sloan Kettering, and I'm soaking feet at Pine Street doing what the nurses told me instead of being at my fellowship. And I remember feeling like I probably had done the wrong, I'd chosen the wrong thing. But it was, what I learned from the nurses is they were exactly right. It took, by soaking people's feet, I was starting to get to know them. They would talk to me, and I'll never forget. I like to tell the story. This one man who I had seen many times in Mass General's emergency room, who had horribly swollen legs from chronic venous stasis, and the skin would break down. Get infected, but he would never see. He had terrible schizophrenia, and he would never let us give him a treatment. And we wrote in the chart that he was very treatment resistant. He had schizophrenia that was treatment resistant. And I soaked his feet Barbara had me soak him. It was about a month or a month and a half. And he finally started asking me questions, including eventually, could I give him something to help him sleep at night? And I'll never forget going, oh my God, this guy. We spent 25 years at Mass General saying he was resistant to treatment. And a month of soaking his feet, and all that resistance had evaporated as he got used to somebody who would be consistently in his life. And
Mhm.
that is when I sort of started to realize that the nurses, in fact, almost everything we do now is all based on the principles that those nurses taught us all.
As I think about where we are with homelessness now, um, the landscape has changed in Boston a whole bunch since you first started with this work. But I'm wondering, how has that landscape changed? And I'm wondering what challenges remain the same.
Well, that is a great question, and we talk about that all the time, Harold. Uh, so I think what has not changed, or not, the fundamentally has not changed, is that there isn't enough housing. There's not enough affordable housing.
Mhm.
Um, and I was taught by a woman. I don't know if any of you remember. There's a woman named Cushing Dolbear, and I remember in 1985. I'm just the first meeting we had of the other programs doing homeless care. She spoke to us in Washington D.C. She had started what's called the National Low Income Housing Coalition, and she pointed out to me one thing, that the government gives the biggest subsidies in housing go to all of us who have mortgages. So that, the mortgage amount of money that we're forgiven is way, way beyond what we give poor people to get into housing. So she was saying that's a little bit unfair. But then she said the only way that she could look at homelessness, now this is 1984 and 85, was to understand that the federal government, which used to fund a lot of very low income housing during the late 70s and early 80s, there had been enough of a financial crunch and recession that they had stopped funding that. HUD had stopped. They went from $90 billion down to about 20 billion per year on low income housing. And homelessness seemed to be, at least be, if it wasn't causal, homelessness was associated with that at the same time. And she said the way to think of it, and this has haunted me since then, is think of it as a game of musical chairs. And what we did is we stopped building the chairs or pulled them away. And when the music stops, there's only enough chairs for those who can get there first. And so who doesn't get there, it's going to be the person on crutches or the person who's distracted by some thought disorder. So she was pointing out that while homelessness is fundamentally the lack of housing, the problem we've created from a public health point of view is that in a competitive world for housing, those who don't get housing tend to be those with the most difficult problems to overcome that get in the way of them getting housing. So what suddenly happened is we started blaming people that was their mental illness or their substance use or something that meant they were now homeless. They were in some way the cause of their own homelessness. And she kept pointing out that don't lose sight of that while yes, they didn't compete very well and they need a lot of help, that's not the cause of their homelessness. And I think that framework has held pretty well through time. What has changed a lot, or let me say, so in the older days, and I used to study a little bit of how homelessness was in the past. It was primarily able-bodied men, primarily men, wandering around looking for jobs. And that's what, like even Pine Street was opened as a place where those kind of people could have a place to stay while they looked for their jobs during the day or worked in poor jobs. But after 1980 or 82, it became the typical homeless person now was somebody with relative, with a big burden of co-occurring medical and psychiatric and substance use disorders, usually histories of trauma, all the things that would have a describe a population that really couldn't compete in a world where housing was really, you know, competitive. And so I think that if you keep that in mind, that sort of describes what's going on. Initially, it was people with AIDS couldn't get housing because they were fighting their illnesses or they couldn't afford their rent. Um, and the classic was, when I first started, it was a ton of alcohol. There's delightful, wonderful old, as Barbara would have said, the old drunks that they love at Pine Street, and they were endearing. And that has shifted now to people that are probably older, people that, as well as younger with families, people that have, severe and persistent mental illness tend to be stuck in those worlds. And now, the evolution, as all of you know, the evolution of sort of, alcohol and, I've worked in the detoxes for, 40 years, and we used to see a rare person with heroin, mostly with alcohol. And now, then it was heroin. Now it's a whole combination of drugs, and that seems to parallel what the homeless population is now. That complicated, uh, it's complicated, but it's this cocktail of different drugs. It's no longer just alcohol or heroin. Now it's fentanyl mixed with methamphetamines, mixed with benzos, mixed with clonidine, and all those other things. And those are the folks now who don't compete very well for the scarce housing we have.
You gave us a story of a moment ago of someone who you watched his feet, for whom you watched his feet, and the person then asked you for some assistance. I'm wondering if you could, and I really appreciate you actually talking about how I'm going to call it epidemic, has changed over time. And you've seen a variety of different populations of folks. To help us get grounded in who we're really talking about, could you give a story about someone that would help to illustrate exactly what you're talking about, and perhaps someone who stands out in your mind that you would say, this is an example of what I'm seeing and what those people who are working in homelessness, are seeing right now? You kind of talked to general, but I want to kind of bring it down to home so we can actually see someone.
The only hard part of that question is trying to figure out which story to tell.
Sure, I
um,
understand.
but uh, you
So
know,
maybe you'll tell us multiple stories.
no, good. And the problem is, it's a little bit like when you tell those stories, it's about that one group of people, but it doesn't say the same thing for many other groups. And
Mhm.
when I think of the complexity of homelessness
Well,
now,
so let me actually just stop with that, because it's actually important in understanding that we're not talking about homogeneous group, that we're talking about a very complex group that
yeah,
presents with many different kinds of things. So I appreciate you saying that when you tell one story, you're telling one story. That when you tell one story, that you're not talking about the whole population of people.
sure. I'll tell you a generational story, which
Okay.
taught me a lot. So I, I gravitated to taking care of the people on the street. Those were the ones we sort of, the team I'm working on concentrated on them. And as everybody knows, in Boston, 95% of everybody who's homeless tonight will be in the shelter, and a relatively small percentage will be outside. And they are, for all sorts of complicated reasons, electing to not go in the shelter. There's place for them in the shelter, but they're electing to not go. And we could talk forever about the many causes, many reasons people don't do that. But one of the, you know, I was out there for years. I spent a lot of time on the Pine Street in Van. I've been able to go out there 2 nights a week until COVID came along and got to know the people outside. But there was a woman a young girl who we got to know really well. She was pretty well addicted to cocaine. She had a very interesting and kind of complex relationship with a young man who was a veteran, but a few years older than she was. And I didn't realize till after I'd known her a while that she was only 17. She was 16 when I first met her, only 17. And when she was just 18, she became pregnant. And at the time, she was living in these tunnels under Copley Square. And I don't know if you've ever seen these, but Copley Square has, you can go down onto the Mass Pike, or underneath that, there's the MBTA line, and then there's Amtrak. So there's three sets of complicated tunnels under Copley Square. I did, for the first 10 years I worked, I had no idea they existed. And down there were tons of people sleeping back they pretty much cleared it out now. But this woman was sleeping with a boyfriend down there, and that's where you could sort of avoid the police. You were safer using your drugs down there than up on the street. And when she got pregnant, she couldn't stop using her cocaine. So we had gotten to know her, and I think she trusted her, and so she agreed to come in when she was 6 months pregnant, because we said, you're not going to be able to keep, if you really want this child, you've got to come in and you've got to get help. So she agreed to come to our respite program, our McGinnis house. But only if we would admit her boyfriend as well, which was a little problematic, as you can imagine. But she came over, and she spent 3 months there, did incredibly well, stopped her cocaine, let us do everything. She was really focused on having this baby. And so she delivered at Boston Medical Center, which is right across from where our respite program is. And she called me the next morning, and she said, can you come over to, my baby's born. Can you come over and take a picture? And in those days, I didn't take many pictures. But she said, my family's here. I want a picture of my family with this baby. So I went over, and I have this picture to this day. I went into the room, and, we didn't have phone cameras back then. So I had to bring a little throwaway camera. Uh, and there she was, sitting in bed with this beautiful little girl who had been born absolutely healthy. And her mother was sitting on one side of the bed, and her grandmother on the other side. And I came in, and I was like stunned, because her mother, I didn't know it was her mother. They had different last names. Her mother I'd known for years. She used to live on the streets of South Boston, and we used to take care of her. In fact, we took care of her, and she eventually died of liver cancer. But she came over and gave me a big hug and said, it's so fun. And looking at this, Katie had no idea. And then her grandmother, who had dyed blonde hair, came over and said, you'll never remember me, but I used to live on the streets of the North End, and you took care of me back in the 1980s. So I'm sort of stunned, sitting back and realizing, here's this baby born to a young girl who's living in a tunnel, addicted to cocaine, who's the daughter and granddaughter of women who had the exact same problem and lost their children. Each of them had lost their children to the state. Um, and I remember thinking of that, this is women, it's generational homelessness, and what are
Mhm.
we able to do to intervene here? And to make the story even a little bit more juicy, and I shouldn't be, going so long here, I'm sorry. But what happened is, about the next day, I came back to visit them again, and they had decided they were going to give the baby up for adoption. And Kate, this woman, and her boyfriend went back to the tunnel, much to our chagrin, as you can imagine. Although the baby got adopted and is doing really well now. But about 2 months after that, the boyfriend was stabbed to death on Boylston Street, standing outside a 7-Eleven, not far from where thing. And she was left alone. So she's now got no baby, no boyfriend, really nothing. And we had a psychiatrist who was full time on our team, who started to meet her at her favorite down at Copley. She lived right by Copley Square during the day, at her favorite McDonald's. That's where he would do all of his care, all of his therapy, all of his medication changes and stuff. It was fabulous, and she loved and trusted him. And then, 5 years later, she transitioned, and went through our transgender clinic and transitioned, got sober, was working, did really well, broke out, and then 2 days after she broke out, about 2 years ago, she overdosed at Copley Square and died. So the whole story just kind of had all sorts of, you're almost there, but not quite there, and you just don't have enough support to make sure everything is there. But I say that story only because it's just complicated. The whole thing is complicated. And if we don't recognize it, when I say generically, if we don't recognize it, there are no easy sound bites in this one. You're not going to solve homelessness the way we have homelessness now, with housing. You can't solve without housing. But she, like so many other people, need a ton of support from all of us to try to make it once they get in housing.
Yeah,
25%. Oh, I'm sorry, go ahead.
no, no, please go ahead. I'm sorry. Didn't mean to interrupt you.
I'm sorry, I couldn't hear whatever that was.
I did not mean to interrupt you. I thought
Oh,
I
no, no, I was finished. I was going on too long.
Okay.
Don't.
Uh, Jim, I actually appreciate that story a lot because it does talk about the complexity and this idea of generational homelessness and just how complicated it is. And while I was every time that I talk to you, you introduce a whole new thing that we've never talked about. And you and I have talked about this many times before, but we've never talked about going down into the tunnels underneath Copley Square. First, I didn't know there were tunnels. I have certainly taken the train and know that it has to go someplace down there, but I didn't know exactly what that looks like. Could you talk about that experience of actually going into those tunnels, what that was like for you? Especially as you think about the early days of your experience and kind of what that challenge was for you in actually going into those tunnels. Fear, no fear, interested in doing it, and being an explorer. What was that like for you?
It goes back so far now. What I initially remember is I was more curious than afraid because I was the same way, Harold. I had been on the streets for, I want to say 5 or 7 years, thinking I know everything about Boston after dark. Had no clue about there were at the time there were about 40 people living in these tunnels underneath Copley Square.
Hmm.
So when I went down there, though, the catch for me, and this is a little twist, is that belongs to like the MBTA, I mean the state police or some one of the police owns and operates that. So we couldn't go down there without a policeman accompanying us, which is
Hmm.
always not great because you don't want to run into somebody, you know, in their bedroom basically when you're with a state policeman. So I wasn't afraid, other than I was afraid they wouldn't talk to us because of the police presence. But it turned out what was nice for us is we knew everybody down there because we had seen them up in the during the daytime up and when they were wandering around. So it was comforting that most of them recognized me. Once one person recognized you, everybody else kind of opened up. So
Hmm.
I think we've had the advantage, or I had the advantage of being out in the van with these folks who are out every night, and they introduced me to all these folks, and then you're not so afraid. So I was not afraid. What I was bewildered by how every time a train went by, the place became black with soot. You couldn't even breathe. And and it was dangerous. It was dark. You had to make sure people stayed away from the train tracks. And people would be in all states of sobriety and inebriation, and you worry about what could happen down there that nobody was looking at. So it was more the fright I had was for how awful it was that people were down there. We got to find some other place for them. And then when you find a 17-year-old pregnant girl down there with some guy who's a little bit abusive using cocaine, that was like, oof. So I think that's where we went. And interestingly, on the streets in the van, I would make a comment that I don't ever remember being afraid when you're with people that are out there all the time. And as you're there more and more, you're less and less afraid until methamphetamine showed up. And
Hmm.
now, as you can all know from Mass and Cass and everything else, when you add methamphetamine to heroin and everything else, then people become unpredictable and it's dangerous. It's a drug. It's homelessness in one way, but it's really much more. The widest circle is a drug world that is dangerous, and homelessness are kind of caught on the edge of that. So we're really cautious now. It's changed. And I feel terrible about that because I now understand that, it's evolved in that sense where it used to be people you want to like hug and bring home and cherish. Now you got to be really careful about what's going on because of what they may or may not be struggling with.
As you were talking about that, it reminded of an experience I had just a few years ago. We were in Puerto Rico and were working with the street outreach group there, and they took us into this. It was midnight. They took us into this old abandoned church building that was filled with people, but it was pitch black and you could not see anything. And the person who was our guide and kind of guiding us through this said, stay close. And he had this little pin light flashlight so that he could guide us through. And he was looking for particular individuals who he knew who were living in this situation. And he wanted to either give them food or some such. And the experience of and I don't know that I was afraid. I was certainly very curious. I certainly stayed very close, but just every once in a while when his pen light would flash out and you could just see this mass of humanity of individuals who were on mattresses and other probably the ground and other places that they were standing. Some were standing, had no idea just what that experience was like. So that's what I was reflecting on as you were talking about your experience of going down into the tunnel. I want to switch gears just a little bit. As you talked about what it meant to go into the tunnels, the thing that I started thinking about is this issue of trust. As you talked about the complication of going down with a police officer. So I'm wondering if you can talk about um, w- the fact that many of your patients experience very complex medical and behavioral health needs. I'm wondering if you can talk a little bit about how you approach trust and providing care for those individuals.
Yeah, I think we often ask ourselves, is there a way to codify how you win trust? And I've decided, as a former bartender, trust is only earned if you're patient and listen, and it doesn't. It comes at whatever time
You
they.
were a bartender?
Most of what I use, the skills I use most in my life right now, were ones I learned during my 20 years of being a bartender, not during my
Okay.
years in medical school. Okay,
Hmm.
so.
Uh,
Um,
we all learn things from different places. So, okay,
You,
bartending.
no, think about it. When you're a bartender, you are behind you're stuck and you're serving people and they're going to talk. And if you don't enjoy listening to them, it is a long night. So I learned to be fascinated by the stories, That's kind of what, where I know I want to get to their hypertension and their diabetes. You got to hear the stories for a while before you'll get to them.
Sure.
And learning to be patient with that was hard for me, but I think I had with a lot of help from the nurses and a lot of help from the other workers there. Just take your time.
Yeah.
And our world is all, as you guys know, it's all about continuity of care. It's consistency and continuity. So you have to take the long view. You can't take the 15-minute visit view or you're going to never get anywhere.
Hmm.
So I think that's what we had to do. We had to say it's okay to not know. I mean, I've stories of being ridiculed by residents because I would know somebody who was an elderly man who I knew for years on the streets who was very paranoid. Um, and I could give you all the stories about it, but he eventually got sick. And when he came in, this is at 10 years after I've been taking care of him, he had never let me take his blood pressure. That was not allowed. So when he got sick with heart failure and a rapid heart rate, we brought him upstairs and we're admitting him to the upstairs with the residents. And they said, well, you've known him 10 years. What's his usual blood pressure? And I said, I don't know. I've never taken it. And I can remember they looked at me like, this guy must have been trained in the dark ages because he's never. But the truth was, it was all that time to get him to trust us enough that we could actually bring him up and admit him to the hospital. That was the victory, but to them, it was something different. So trust takes a long time. And I worry that we don't give most of I mean, we've had to learn in our program, we've had to give people that time where you'll never get good results. But going very slow in the beginning is the best way to get better results down the line. But if you're going to judge somebody on what's happened these last 3 months, you will fail miserably by that standard.
So I appreciate the whole issue of talking about taking slow. One of the things I like to tell my students is that it's important for them to get to know people and that you get to know people by listening to them and engaging with them. And then in time, they will maybe you will get to know them better. But in time is the key piece there. Jim, talk about, a little bit about healthcare for the homeless, because as you talk about your program and what you've learned, you keep referencing that, and perhaps many folks here know some, but would you tell us a little bit more about Boston Healthcare for the Homeless?
Yeah, no, I'd be happy to. It's like what I love dearly. Uh, but Healthcare for the Homeless was a grant from the Robert Wood Johnson Foundation to the city of Boston. It was given to Mayor Flynn back in 1985, along with similar 4-year grants to 18 other cities around the country. But they had an interesting twist to it because I'm a resident. I had nothing to do with the conceiving of the grant, but the mayor had to get a coalition of homeless people together. They met at City Hall to find out from them how they wanted to be served so that that would go into the grant because it couldn't be what the mayor or we at the hospitals wanted. It was what the homeless people wanted. And you guys all probably know that to this day we have homeless people on our board of directors, who still, you know, hire and fire us essentially. But so they just their concern was they wanted, and this is where continuity of care came from. They hated fragmentation and loss, and they would always see somebody different in the emergency room. Nobody would follow them up, or nobody had the ability to follow them up, and they could never make appointments. So they wanted doctors and nurse practitioners and PAs basically to come join the nurses who are already in the clinics, but to come out of the hospitals and go to wherever they were. So our clinics are in essentially all the shelters, and we have regular like Pine Street Inn 7 days a week. We're there 14 hours a day. And at St. Francis House, you name them, almost all of the adult shelters and virtually all the family shelters, we have clinics in. But they wanted those clinics anchored by a real place in the hospital. And this is where Boston City Hospital and Mass General turned out to be unique in the country, where they said, we'll let these folks have a clinic in the hospital and be credentialed and be part of the hospital's regular life. So we've always had to be credentialed. We attend, as many of you know, because we've done it with you, is attend on the wards and teach medical students. And it's been like a miracle for us because it allows us to be part of a larger system instead of a separate system of care, or as I used to think, as banished. So we were supposed to be a catalyst within the mainstream and not an alternative system of care. That was how the foundation did it. So, and then the other thing homeless people insisted we do was come up with this thing called respite care, that was a 1984 request because they were so angry with us for discharging them from the hospital, and they were way too sick to be wandering the streets. Or even, you remember at Pine Street, all the shelters would tell people they had to leave at 7 or 7:30 in the morning, couldn't come back till 4 in the afternoon. So that's where respite came from. And Governor Dukakis gave us beds at the Shattuck shelter back in 1985 when we opened the early McGinnis House was over there. And that was kind of our model of care, right? So it was hospital, it had to be continuity of care from street and shelter to hospital to respite. That's how they placed it. So that model we had nothing to do with, but it's kind of an effective and interesting healthcare model, for a population that doesn't have a stable place to be. So we chase them around. So many of our patients, as you know, Harold, and certainly Al knows this, we'll see them at City or Boston Medical Center in our clinic, but also see them at Pine Street or Long Island in the old days. And then if they hit the streets, we'd see them out under a bridge, because we would be the continuity in the system. And it turned out to be a delightful, wonderful job because one, the medicine was fascinating, and the public health aspects were really complicated, but also fascinating. And then it was kind of a joy because you didn't have the usual productivity issues and all that stuff to get, we could take as much time as we needed with someone to get them in. And I think it sort of described back 40 years ago what I think of now as a patient-centered medical home concept, or something along that. So that's essentially our model, though. We now also have had to extend it because so many of the people we've been following for so many years go from the streets or the shelters into housing. And we found out that's when they need almost more care. So we decided continuity had to go. We didn't decide. Our board of directors, the homeless people on our board of directors said, just because I get housed, you can't abandon me. So we now do an awful lot of home visits, taking care of people at home, which is weird for a street team doing a lot of home visits. Just doesn't make sense on the surface.
Jim, I'm going to invite our audience to let us know if they have questions. Please either raise your hand um, or write something in the chat so we can respond to your question. And while I'm waiting for that, again, each time that we have conversations, there are more things that I want to actually talk to you about. But as I think about the book that you wrote, I'm wondering if there are um, misconceptions that people have about homelessness that you would want to help correct.
Um, I think there are a couple of things I would share, but they're not profound. One is that we all, and since we're all in some version involved in healthcare, I guess, it's complicated. So I'd say, please understand this is complicated. And when I think of who's homeless, it's kids, it's adults. I mean, it's kids, families, adolescents, it's young adults, old adults, it's people with AIDS, it's people with all sorts of disabilities, and you name it. And they're all mixed into this thing called homelessness. So there's no one solution to this. There's going to be, we have to have a lot of creative solutions to answer this. So I never believe any soundbite anymore. That's one thing I would say. And
Mhm.
then I think the other thing is just to, the more I'm at this, the more I am stunned that I don't think we've ever found anyone who wants to be homeless. So there's no one who's out there saying, I want to be homeless. And when you get to know people's stories, they're kind of mind blowing, and the problem is you don't learn that story until you've known them for a long time. For many of them, it's a long time. So I think if we could somehow convey that these are people that have had terrible stuff happen to them along the way, have been dealt a really terrible hand in life, not someone who just lost their job because they were strippers and ends up on the street. That's so rare. Um, and think of this, you guys, just as a stat: 25% of the men we see out on the streets of Boston cannot read or write. So you realize that whatever caused their homelessness didn't happen last week or 2 weeks ago. It happened back when they were kids.
Mhm.
Um, and I think that's a theme there's so much trauma, childhood trauma, so much, you know, physical, sexual, emotional trauma and neglect and isolation that, that's what we're up against. So a lot of sympathy, I think, is required to understand that their behavior is not really coming from the same places we usually understand.
I see a couple of folks who want to talk. So, hello, Lewis. It's good to see you.
Thank you. I'll unmute. Thank you very much, Harold and Jim. Nice to hear your voice. Just one quick comment, and then I'm going to go back to what you just finished with, which is the comment is I read the book, but I also listened to it recently, and I thought the listening to it added just another dimension that made it much more lively than reading it, because I was stuck in my own head reading it, but listening to it, it's almost sounded like you talking. I thought it was very well done, the way it was. If so, people have a chance to listen to the book, that would be beneficial. So just to get back, I'm a pediatrician, and you're trained in internal medicine, and I was also intrigued about how the book brought out the early life problems of so many people you were dealing with. And we have a term for that in pediatrics, which is it's ACE, adverse childhood experiences. And that it's a term that really is fairly recent, maybe in the last 10 or 15 years. And I wondered if you had a chance to maybe speak with pediatricians or others, to be people that care for kids, psychologists and sociologists and so forth, who deal with children, to understand really how bad this is, these adverse early childhood experiences. Thank you.
Yeah, and it's actually, Lou, it's great to see you, by the way, and you bring back great memories here. Uh, the truth is, yes, we have been all over ACEs because the more, as we got to know more and more about the families and the kids and stuff, we just were stunned by what they'd lived through. And when you talk to the people on the streets who've been there for 20 and 30 years, then their childhood episodes become mind-boggling. We have several pediatricians on our staff, and they are very all over it. We actually, believe it or not, generally stopped asking about ACEs because everyone had
Mm,
all, and so it stopped becoming helpful for us to say who needs more than not. But suffice it to say, we don't know anyone who hasn't endured huge numbers of adverse childhood conditions. I have been asked several times, if I had some money, what would I do to end homelessness? And I know the answer is, we surely need housing. But if I could devote money to one thing, I would pay school teachers and early childhood education teachers $100,000 or $200,000 to take care of, because that's where it can be stopped. The prevention of homelessness is right there.
mm,
We can just
thank you.
listen to people.
Wow.
Thank you very much. Hello, Sue.
Hi there. Hi,
Hi,
Jim.
hi, Sue. How are you?
Good. How are you?
I'm good, thank you. Just getting old, slowly getting old here.
Very well.
I have a question. First, Jim, Harold, thank you so much for this conversation. It's a marvelous conversation. Um, Jim, you said that there were, I think, 17 original grantees. But are any of the others still, quote unquote, in business? And are there other principles to their continuity, secrets to their success?
Oh, it's a great question, by the way, because um, all of them are still in gear, and the federal government now funds us. So the grant ended in 1988, and as many of you may know, we were then funded through the health through PHS as health centers, and we're we were initially funded as healthcare for homeless programs, migrant health centers, and community health centers, all through the same funding stream, which allowed us, by the way, since we didn't have grant money anymore, to begin to bill Medicaid. So we've been able to sustain ourselves by learning how to bill Medicaid. And because we live in Massachusetts, which has a pretty generous Medicaid package and has expanded Medicaid coverage over the years, it's been sort of a great way to go relative to my friends who do the same thing in Texas and other states that don't have the same joys. So the government has now got, I think it's 330 healthcare for homeless programs, virtually in every state, Puerto Rico, et cetera. Unfortunately, though, or fortunately, whatever the right thing is, there's no like model. They all look different. It's all money given to the city or public health departments, community health center, and they all figure it out by whatever the local pressure is on them. What I would urge, and I'm trying to figure out how to say this properly, not only locally but nationally, is that I think what has distinguished us over the years has been the fact that we were welcomed by a shelter community, by the state and city, leaders, political leaders, and by the hospital community. Because we could, our leading cause of death, even though drug overdose is sort of slightly the most, right under drug overdose is cancer. Second is heart disease, and there's, liver and lung disease. So we can't deliver good care unless we have access to really good specialty care, which we can do at Boston Medical Center. We can do that at Mass General. So anybody we see, because we're part of the hospitals, we can get right into their care. You don't have to refer them from the outside in. And as far as I can tell, there is no other hospital, no other city in the country where there is a major academic teaching hospital involved in the care of homeless people, despite the fact I would say they're arguably one of the sickest populations we have. So we've been really blessed to, to be part of this community that you all know so well, the public health community. It's been great. We have 30. It took us 5 years to find a second doctor back in 1985. We now have 35 basically full-time doctors on our program. Most of whom have been trained in all the hospitals and programs that you guys know very well. And that is truly due to the fact that we've been accepted by a world beyond ourselves.
Jim, thank you very much. Jim, before we go to the question that's in the chat, I have to ask the question that I ask you every time we have a conversation like this. Have you read the book yet?
Oh, you're embarrassing me. No, in all fairness, I love Tracy Kidder, and he spent 5 years with us. He is an unbelievably wonderful human being, but I have not been able to read the book. No.
Okay. All right. I actually knew the answer to that. Because every time I ask you that question, it's the same answer. I'm just expecting that one time you're going to tell me, yep, I did. So I'm going to go to Ed's question, which was, what was it like to collaborate with Tracy to create the book? And what kind of impact do you think the book has had?
Oh, a great question. And I think about this a lot. One, I knew Paul Farmer really well. He was a student. When he was a student, he came to Pine Street to visit us. I was older than he was, to learn about the TB epidemic that was going on. And much of what he later did in Peru, he learned at Pine Street Inn, believe it or not, you guys. He didn't talk about that much. But then when Tracy wrote Mountains Beyond Mountains, I love that book. I love the story. I love the book. And I can't tell you how many people I know are now doing public health or medicine or nursing because of reading that book. So Tracy has a real gift. And when he came on the van one night and said, hey, he was writing a book about Paul English. came on the van and he saw the people we were seeing on the street and he said, "Hey, I might want to write about this. Are you okay with that?" And we said no, as you might imagine, because it's kind of an intimate dance out there, and you don't want, like, the police are not who you want to have next to you, and you certainly don't want to have a journalist next to you when you're seeing people. But our board of directors, the people on our board of directors, the homeless people, when they heard it was Tracy interested in writing about them, they insisted that we say yes. And so he then spent the next 3 straight years he spent with us, just embedded in our team. And I mean 3 straight years, 5 days a week, nighttime. He came on the van, he came on home visits, he was just part of our team. And then another 2 years until COVID came, and then he stopped. But interestingly, he said right from the beginning, it's his book, he's writing that book, so we had no editorial say in whatever. But as he said, he doesn't do hatchet jobs, so at least we were comforted by that. And I grew to really admire the man, because I would be, outside seeing somebody, talking to them, and when they'd see Tracy come over, they'd say, "Excuse me," and they'd go want to talk to Tracy, because he just spent hours talking to people. So he got rid of all of our misgivings. And then when the book came out, I think I mentioned to you this, Harold, when the first copies came out, he signed one for every homeless person that he had talked to, which is, I'm going to guess, is, a couple hundred at least, that he had talked to in depth, and then a wider thing. And he gave them all a signed copy of the book, which I thought was a real interesting, cool thing. Now, of course, we had never read the book, so we didn't see anything until the book was out. So we didn't have any editorial thing. But when it came out, the only criticism we got, this, leave the literary stuff aside, only criticism we got was from our patients who were not in the book. And
Why didn't you include me? All right.
and it it just underscored for us, these are people who have lived through hell and want someone to tell their stories with some kind of compassion and, and care. And that's what he was doing for them. He was telling the stories. And we had initially thought, we don't want them to be with us because these are people that want to be anonymous and not be, have somebody in their face. So it was a real learning lesson for me. And then since then, we've gotten to know Tracy really well. He's got grandchildren who live in Jamaica Plain, so we see him all the time. And he's a treat. He's a real treat.
Jim, we are at the end of our time. And oh, Emmy, do I see your hand? Hey.
Yes, I just wanted to ask, I live in the Neponset section of Dorchester, and we're about to have a Pine Street Inn extension, or whatever you might want to call it, down here near Tenny Ann Beach. And our civic association has, of course, reservations about it for, a number of reasons. But I find myself, after reading your book, looking forward to having this community in our neighborhood so that we can create that community. And it was based on, what is it, Verghese said in your review in the back, "I am left in awe of the human spirit and inspired to do better." And there's a part of me that wants to do better with this community that we're about to have here in our neighborhood. And I was just interested in any comments that you might have to alleviate some of the concerns that the Civic Association has.
No, and I mean, I now live in Jamaica Plain, but I lived in Savin Hill for many years. So we were right on Marcy Boulevard.
Yes.
And so I've lived through much of that, and I try to stay kind of calm about this because I've seen programs like that, and Pine Street runs really good programs where it's actually becomes a magnet for the community. The community is drawn to it because you can help people and do that, and it works incredibly well. If it's not done well, and you bring a lot of people and put them in one spot, it can be a nightmare. So I sit on the fence. I know we need more and more housing, but it has to be done right, or else it can be a nightmare for the community. So my thing is always to make sure I understand what are the supports that are going to be there, and what if something goes wrong, who's going to be responsible, so you the community can ask. And I think Pine Street's used to that, and they've learned. I mean, I shouldn't say the hard way, but they know if you don't do well in a community, and I mean, Pine Street, some of the early housing they have on brownstones on Beacon Hill. I mean, on Beacon Street on the Brookline Boston thing, and you would never know it's a homeless program. And the neighbors love it. They drop food off. And so it can be really a wonderful experience, but it can also, if it's not done right, can be awful.
I'm
It,
I'm looking forward to it. It's a lot different than having the Howard Johnsons there.
And I mean, well, the way you just described how you feel is so wonderful to hear, by the way. Thank you. Because in most of the community meetings I've been to, it's not been very pretty. And, you sort of understand both sides, but it's not pretty.
Emmy, I really
Thank you.
appreciate your question because it really raises the issue about currency and about where we are right now and what it means to actually be with the population and supportive of the population at this particular time. I'm going to take the license of the moderator and just extend this just for a couple of minutes and see if there are additional questions that we have, because I think Emmy actually opened up something really very important. We did not talk about mass and caste in our conversation today. We didn't talk about what are some of the specific things that are actually happening in our community. So, Emmy, I appreciate you talking about what's happening in your particular community. But I'm wondering, before I ask my last question, if there are other questions or thoughts or expressions that any of you have that you would like to share with us. Al.
Yeah, thanks, Hal. I just want to say that, in reading the book and listening to Jim over the years, I've come to appreciate how contingent the experience of homelessness is on what's going on in society. I'm losing my voice. Society. And, thinking back to when I was at Boston City Hospital in the 70s, when the Pine Street Inn was actually on Pine Street. And I would say 80% of the people experiencing homelessness who got admitted to the hospital were older men whose drug of choice was fortified wine. And 20% were people I now see as sort of typifying current homelessness. And sort of this appreciation for the evolution and how societal factors control that evolution, and maybe be more strategic about addressing specific societal factors.
Yeah, Al, you're bringing back that's exactly because I started just so you were ahead of me because I was so far behind. I was so late in getting to medical school. But when I got to Boston City in '85 and Pine Street, that was largely exactly who we were seeing. And it was a very different, and what changed, I know so for example, the TB epidemic was entirely among men who were drinking alcohol who were not immunocompromised. So that was that. But then AIDS came along, and all of a sudden we started seeing, people losing their housing because of all the stuff that came with AIDS. And a lot of it was IV drug use that was causing it. So we started to see more of a different population beginning right through the next 10 years. And I think it's just evolved. Whoever is suffering most in society ends up being in the next wave of homelessness. But I'm with you on that. It is so much a part of whatever's going on in society. You can almost tell what's going to happen. For example, I'm sure all of you know that if two people in Boston work 40 hours, a couple works 40 hours a week at minimum wage, they cannot earn enough money to rent a one-bedroom apartment in Boston. And that, I think from what we could tell, was the first time in our history that somebody working hard can't afford a place to live. And I think that in itself is creating, new homelessness all the time. So that, that was new. That didn't happen back in the 80s or 85, but now that's the new thing among many others. But you're asking or pointing out a really important thing that I think I'm still struggling to get my arms around and learn. And I think the book about homelessness still needs to be written. It's a complicated problem.
What would be in that book? Jim.
I
So
missed
you
that,
said,
Harold. I'm sorry, I
yes,
missed that.
you said the book still needs to be written. And I'm wondering what would be in that book?
So Okay, I'm going to give you real pop psychology here because
Okay.
as Harold and I have talked a lot. The government does not invest money in studying homelessness, so we don't have any good studies. We have small studies that are often flawed, including our own, about trying to understand this, and we could go on because, as you know, Harold's teaching the first course on homelessness at the School of Public Health, and there were none at the Harvard School of Public Health, none at Tufts. It's crazy. It's a big public health problem, but we're not even looking at it, although the citizens think we study it to death.
Hmm.
But I would say one of the things that it haunts me now is that this big societal problem of homelessness is only going to be solved when we figure out how to, on a massive scale, do housing. But we also have to address the flaws in our education system, our labor system, our welfare system. It's all those things that don't serve people well who are poor that end up 20 and 30 and 40 years later with somebody who's homeless on the streets. So to fix that, that's the answer to ending homelessness someday. We got to fix all those things. But what I think we all get caught up in, when I say we, when we're talking about homelessness and how to fix it and what to do, we get caught up in focusing on that part, which is going to take way more than any of us have to do. We're going to need a big societal thing. But in the meantime, and this is where our little program gets caught along with others, our job is not to end homelessness. We're trying to take care of the people who are out there, make sure that they don't die forgotten or that they have the best of care that we can provide, even though the determinants of their health or ill health probably happened 20 or 30 years ago. And we can't change much of that. So I look at the issue that people have a hard time with is how do we take care of the people that you're seeing out there in a humane and good way, like we would do with any population, and not let that get in the way with the fact that to end homelessness, we're going to have a major societal change. So I see people not putting money or time or effort into taking care of individual homeless people and putting their money into housing. Just okay, but there's no balance. When there's no balance, you end up with kind of the thing. So I'll give you an example that, severe and persistent mental illness is about, if you look at the chronically homeless population, it's probably 25 to 30% of the people who are there. And when you say, how many psychiatrists do you think are involved in taking care of homeless people? It is virtually, I think in the country, we could count 6, who do it. I mean, everybody might do it a little bit on the edge, but there's no one out there who's funded to go take care of this population. But we'll always talk about the mental illness and this thing. It's crazy making. But it's because if you look at the ultimate solution, you tend to miss the care of the people that are stuck there. That's way too long. And I'm sorry, you guys, that was like whining more than telling anything.
Well, but it's such an important thing to actually say about how complicated it is, and that there are many different facets of thinking about caring for the homeless. That it's not just the policy stuff, but there is also the need to think about um, services that are needed for individuals, housing, but then all of the other kind of wraparound things that are important as well. So I just have this one last question for you. If you were to give some advice for either medical professionals or students or advocates who want to work in this field, what would you tell them?
I would, first of all, I tell them never listen to somebody as old as I am. So you're going to be listen to someone who's a little bit younger. But I tell them that, look, if you're interested in medicine and you're interested in caring about people and interested in, really being a part of somebody's life and getting to take care of them, this is a great job. We get into the lives of people in ways that I would never have been able to if I'd stayed fully in the hospital. I see people at home, you see them, that whole, and I think most of the people that work with us were residents and students with us at some point and got a chance to see what it's like, because the money isn't what draws you into this, I can promise you that. But the lifestyle and the ability to care for people with a little bit of time and dignity and hope is kind of really, I think, magical. And it is complicated medicine. So if you're interested in medicine, man, or if you're interested in whatever you call it, pediatrics, or if you're interested. And then the last thing I would say is that we are desperate for the best subspecialists and specialists to be part of our lives. Because, when we have the neurologist from BMC come over and do clinics at McGinnis House, it's like magic. You know, we have the vascular medicine people at MGH do a special clinic. So we can send somebody in and there'll be vascular medicine, surgery, radiology, all right there to see them in one spot. And then we realized we can deliver really good care because those people are available. So I urge everybody, no matter what specialty you're going into, please keep in mind, you know, how much good you can do with people like this. But if you're interested in pediatrics or any kind of primary care stuff, come join us. It's really wonderful.
Jim, on behalf of the people who are here and so many others who are not, who have read the book and who have been influenced by you, I want to thank you for everything that you've done in the past. I want to thank you for everything that you're doing right now. And perhaps most importantly, I want to thank you for everything that you are influencing and that you will be doing for us in the future. So thank you so much.
Thank you, Harold. And I'm a lucky guy. I lucked out with all of you. So thank you very much. Okay.
Al, I turn it back over to you.
Yes, let me join Harold in thanking you not only for this, for all the things you do and for the help you've been to the museum and for creating Boston Healthcare for the Homeless program, because I think I can say on behalf of my public health colleagues who deal with issues that come up every day across a variety of health problems, I don't think there's any organization, agency that's better to work with than healthcare for the homeless. It's you know, when you have to deal with something, there's a lot of organizational resistance. But with healthcare for the homeless program, they just see the problem and deal with it, and effectively almost always. And if not, it's not their fault, and we try to find them help. So it's just a can-do attitude that is so inspirational to we in public health.
Thank you. Thank you very much, Al. Appreciate that.
And thank you, Harold, for moderating magnificently once again. And let me invite people to keep in touch with the Public Health Museum. If you're not on our mailing list, please join the organization and contribute and get on our mailing list so you know what's going on and with the book club and with other programs. We're having programs for public health week this year. Our state epidemiologist and public health veterinarian Katie Brown is going to be talking about avian influenza on April 7th, and we're going to have a forum on local public health moderated by Harold on April 11th, along with other events at the museum. So please keep in touch and keep abreast of what's going on. And thank you all for joining us this evening.
Thank you.